Welcome to This Explainer. Today, we're diving into a condition that, well, it's pretty often misunderstood. A lot of folks think pneumonia is just a simple infection you catch from someone coughing on a bus. But actually, it's a fascinating biological perfect storm. It's this incredibly precise cascade of anatomical, mechanical, and immune failures. So, we're going to decode exactly how microscopic pathogens manage to breach our defenses and cause massive consolidation in the lung. Here's our roadmap for This Explainer. First, defining a threat. Second, classifying the invaders. Third, we'll map out that perfect storm. Fourth, patterns of destruction. And finally, clinical clues and complications. All right, let's jump straight into Section 1, defining the threat. This is where the battle actually happens. Before we can really understand this infection, we've got to locate the battlefield. And looking at this definition, the absolute crucial detail here is the location. The lung parenchyma. We are talking specifically about the bronchoalveolar tissue, those tiny bronchioles and the alveolar sacs where the actual gas exchange happens. When an infectious etiology like a bacteria or a virus manages to get all the way down into these deep pockets, it triggers an intense inflammatory response. And depending on just how aggressive the battle gets, that inflammation and pus can literally spill over into the interstitial space or even the adjacent pleural lining of the lung. Moving right along to Section 2, classifying the invaders, or more specifically, where was it acquired? Now, notice how the time frame completely shifts the pathogens we're looking at. The local environment essentially dictates the specific bacterial flora. So if a patient gets community-acquired pneumonia, or CAP, we're usually dealing with your standard everyday pathogens, like strep pneumo. But if they're in the hospital, the flora changes entirely. Hospital-acquired and ventilator-associated pneumonias expose patients to highly dangerous multi-drug-resistant bugs, things like MRSA and Pseudomonas. Truly understanding this classification is absolutely crucial because it's what dictates those life-saving antibiotic choices. And what's really fascinating here is this single number, 48. This is the critical 48-hour cutoff time that doctors use. Here's how it works. If a patient develops symptoms less than 48 hours after being admitted to the hospital, it's considered community-acquired, meaning they brought the bug in with them. But if symptoms start more than 48 hours after admission, or say 48 hours after being put on a ventilator, then the hospital's resistant pathogens are to blame. That simple 48-hour mark literally changes the entire treatment protocol. Okay, Section 3, the perfect storm. This is all about a cascade of failures. So here's the real secret about pneumonia. Just being exposed to a pathogen, that rarely causes the disease on its own. A whole cascade of internal failures has to happen first. Step 1. Obviously, the pathogen has to actually enter the lungs. Inhalation of respiratory droplets is super common, but aspiration is actually a massive culprit here. This is when oral or gastric secretions literally slip down the trachea. We see this a ton in patients with reduced consciousness, strokes, or severe alcohol toxicity. We also see what's called biofilm seeding. That's where bacteria basically flick off of ventilator tubes right into the lungs. And though it's rare, hematogenous spread, where an infection already in the bloodstream, like endocarditis, seeds directly into the lung tissue. But here's the thing. Entry just isn't enough. Next, our mechanical defenses have to fail. Normally, we cough out invaders, or our microscopic cilia beat the mucus upward to clear it out. It's a pretty amazing system known as the mucociliary escalator. But look at these roadblocks. Smoking and COPD, they literally destroy those cilia. Cystic fibrosis creates mucus so incredibly thick, the cilia just can't move it. Heavy sedation completely suppresses the cough reflex, and anatomical things like tumors can physically block the exit. Basically, if you can't sweep or cough the pathogen out, it's going to stay right there and replicate. All right, so the pathogen is in the lung, and the body can't clear it. The final barrier left is the immune system. If a patient is dealing with immune suppression, maybe from advanced age or HIV, their T cells simply don't mount a strong enough initial response. Or, in another scenario, a primary viral infection like influenza or COVID-19 might come in, completely shred the lung's epithelial lining, and totally distract the immune system. And while the body is busy fighting off that virus, an opportunistic bacteria like Staph aureus sneaks in and causes a massive secondary bacterial superinfection. I really want to just pause for a second and reflect on this quote. Pneumonia isn't just about inhaling a bug. It's a cascading failure of the body's physical and immune defenses. Right, it requires the pathogen to get in, the mechanical clearing mechanisms to completely fail, and the immune system to be overwhelmed or suppressed. It truly is a perfect storm. Let's move into Section 4, patterns of destruction. These are the microscopic footprints left behind. So once the infection actually takes hold, it leaves these very distinct, visible footprints on the battlefield of the lungs. And it begs a really fascinating question. How does this infection physically spread inside the lungs to create those solid white patches of consolidation you see on a chest X-ray? Well, the crucial point to grasp here is that different bacteria behave totally differently. In lobar pneumonia, which is classic with strep pneumo, the infection starts deep inside an alveolus. From there, it spreads directly to the next alveolus through these tiny microscopic holes called the pores of Kohn. It honestly acts like a flood, just filling a single, entire long lobe with pus until it hits a physical boundary, like a fissure. On the flip side, we have bronchopneumonia, which we often see with Staph aureus. This one starts higher up in the bronchioles and splinters downward into multiple different alveolar sacs. So instead of one solid block, you get this patchy, multifocal spread. And then there's interstitial pneumonia. Atypical bugs like mycoplasma or various viruses do something totally different. Instead of filling the alveolar sacs up with pus, they essentially cling tightly to the alveolar walls. The immune response then causes these walls, the septa, to become incredibly thick and inflamed. So on an X-ray, this doesn't look like a solid white block of pus at all. It looks way more like a lacy, diffuse reticulonodular web. All right, final section, Section 5, Clinical Clues and Complications. This is all about the bedside presentation. We've been looking through the microscope, but now let's zoom out and see how these microscopic battles actually translate to the symptoms a clinician sees at the bedside. Generally speaking, clinicians divide the presentation into typical and atypical. Typical pneumonia hits hard and fast. We're talking sudden onset, high fever, a nasty productive cough fills with pus, and that classic lobar consolidation. Atypical pneumonia, on the other hand, which you've probably heard called walking pneumonia, has a much more gradual, insidious onset over weeks. Think dry cough and a low-grade fever. But the most important clinical pearl here isn't just about the symptoms. It's the fact that atypical pathogens lack standard cell walls, which means they require completely different antibiotic treatments. It's a real game changer. Now, what's absolutely fascinating here are these extrapulmonary clues. Atypical pneumonias frequently cause some truly bizarre symptoms outside the lungs. Like if a young adult living in a dorm has a persistent cough and you look in their ear and see bullous myringitis, which is literal blisters on the eardrum, that is a massive red flag for mycoplasma. Or if an older patient comes back from a cruise ship with pneumonia, plus confusion and diarrhea, you absolutely have to suspect Legionella. The fact that a lung infection can cause a target rash or even autoimmune anemia just shows how wildly systemic these pathogens can be. Speaking of critical clinical clues, let's pivot for a second to patients who inhale gastric or oral secretions. Why is distinguishing aspiration pneumonitis from aspiration pneumonia such a make or break clinical decision for doctors? Well, this perfectly illustrates the difference. Aspiration pneumonitis is literally a chemical burn from stomach acid. It causes this rapid, frankly terrifying respiratory distress. But because it's a chemical burn and not an actual infection, it usually resolves on its own in a day or two and requires absolutely no antibiotics. Aspiration pneumonia, however, is when the bacteria from those secretions actually stick around and colonize the lung. That develops slowly over days, sustains a really high immune response, and absolutely requires targeted antibiotics to save the patient. You do not want to mix those two up. So when a patient actually does have a fluid-filled bacterial consolidation, their chest physically changes how it transmits sound. It's wild. Healthy, air-filled lungs normally muffle sound. But a lobe completely filled with pus, that conducts sound incredibly well. This causes increased tactile fremitus, which means you can literally feel the vibrations on their back when they speak. It sounds totally dull when tapped. And amazingly, if you have the patient say the letter E, the fluid distorts the sound so heavily that through a stethoscope, it actually sounds like an A, a classic sign known as egophony. Of course, the absolute most dangerous complication of all this fluid is hypoxia, a severe lack of oxygen. Let's break down how this escalates based on severity. In a mild to moderate consolidation, you get what's called a V/Q mismatch. Some air still gets in, but it struggles to cross that barrier of fluid. Giving these patients supplemental oxygen usually helps overcome that. But if the lobe is completely socked in with pus, no air is entering those alveoli at all. The blood just runs right past without picking up any oxygen whatsoever. This is called shunting. And tragically, in this case, giving them 100% oxygen just won't fix their oxygen levels because the oxygen physically cannot reach the blood. Ultimately, that severe hypoxia triggers chemoreceptors in the brain, essentially sending the body into a state of total panic. This drives acute respiratory distress, presenting as dyspnea, rapid breathing, and an incredibly intense work of breathing. The patient is literally using every single accessory muscle they have just to survive, which very often leads to requiring mechanical ventilation. So we've seen the whole picture now. If pneumonia is truly a cascading failure of our physical and immune defenses, it leaves us with a pretty vital question to end on. How can we better protect our mucociliary escalator in our everyday lives? Whether that's avoiding smoking or actively managing chronic diseases, how do we stop the perfect storm before it even has a chance to begin? It's a really powerful reminder that lung health starts way, way before the infection ever arrives. Thank you so much for joining me for this explainer today, and keep asking those great questions.